So we'll just move on in the program, and the next presentation is by me. It's on atrial fibrillation management. And perhaps I don't, by way of introduction, I don't need to remind this audience we're dealing with the commonest cardiac rhythm disorder. And if in this room you're age over 40, I'm afraid your lifetime risk of developing atrial fibrillation is 1 in 4. And if you're lucky enough in our lifetime not to get a heart attack or heart failure, your lifetime risk is still about 1 in 6. And atrial fibrillation, of course, confers a risk of stroke, mortality, heart failure, impaired quality of life, and increasingly recognized dementia as well. So, atrial fibrillation management, often regarded as complex and difficult, but hopefully I can persuade you this is actually can be made simple, streamlined across the pathways from both primary and secondary care, and it can be as simple as A, B, and C. These are my disclosures. I'm not going to read every line in the interest of time, but put into context whatever I say or speak in this presentation with regard to these disclosures. Now, in terms of atrial fibrillation management, I'll start off about stroke prevention. And atrial fibrillation increases the risk of stroke fivefold. This risk is not homogeneous. It depends on the presence or absence of various stroke risk factors. The more common and the more validated stroke risk factors have been put into risk stratification schemes, and the one used in most guidelines internationally is the CHA2DS2-VASc score, which is shown here. Now, the CHA2DS2-VASc score is not meant to include every stroke risk factor. It includes the more common and the more validated ones. The differences from the older CHA2DS2 score are highlighted in red because age is a powerful driver of stroke risks. Age 65 to 74 gets 1 point. 75 and above gets 2 points. Then we have complex vascular disease with previous myocardial infarction or peripheral artery disease. And female sex category gets 1 point because it's a risk modifier. Females age under 65 and no other risk factors, there's no excess of risk. It's females over 65, or if there's another stroke risk factor, being female is additive to that risk. Can I point out that the CHA2DS2-VASc score is merely a simplification? And just to give you an example, age 65 to 74 gets 1 point. Now, it's only common sense. Patient with atrial fibrillation who's age 65 is going to be significantly lower risk than somebody who's age 74. The fact that it's a simplification again, somebody in your clinic which is age 74 and 11 months gets 1 point. They come back 4 weeks later to your clinic, they become 75, they get 2 points. It doesn't mean that the stroke risk is doubled. These are risk scores that are simplifications to help our decision making. And the CHA2DS2-VASc score, as mentioned, is to help the decision whether or not to start anticoagulation or not. And just to highlight the limitations of such a simplification, you see some guidelines categorize patients as low risk and moderate risk and high risk. And of course, we look after patients, they don't fall into 3 little neat categories of being low and moderate and high because risk is a continuum. And risk is also dynamic because if you look at risk factors, whether clinical risk factors within the CHA2DS2-VASc score or this current obsession with biomarkers and things, they measure something at baseline. They look at an outcome of interest, for example, stroke or mortality 5 years later or 10 years later. Guess what happens in the 5 years and the 10 years? Well, firstly, the patient gets older. They get incident risk factors. So we tested that issue about the dynamic nature of stroke risk factors by this study because we looked at the CHA2DS2-VASc score at baseline. We look at the CHA2DS2-VASc score at follow-up. We look at the change in stroke risk profile, and for brevity, I'll call it the delta CHA2DS2-VASc. Here's the prediction here, and you see that that's the baseline CHA2DS2-VASc follow-up, and then the delta CHA2DS2-VASc, and actually the best prediction value on the ROC curves here, the best prediction value for predicting a stroke is the delta CHA2DS2-VASc. In other words, a change in the risk factor profile is associated with higher risk of stroke. As seen on the pie charts where the patients who sustain an ischemic stroke, the majority show a change in their risk factor profile. Message to take away, risk is not a static one-off process, risk is a dynamic process. And there are similar data that we published looking at bleeding risk as well, also highly dynamic, and it's the change in the risk factor profile that is more predictive of outcomes. Now, risk scores are simplifications, and of course the components within the CHA2DS2-VASc score don't necessarily all carry equal weight. So this is what we looked at, and you will see here, these are patients who initially at baseline were low risk with a CHA2DS2-VASc score 0 in males or 1 in females. Here we see the cumulative risk of different risk factors. In blue, at the top here in blue is hypertension, then is age over 65, there's heart failure in yellow, diabetes in red, and vascular disease. So whilst we tend to focus a lot on what the score is, the components within the CHA2DS2-VASc score don't necessarily all carry equal weight. But from a practical point of view, your question might well be, you define somebody as low risk, when should you reassess the patients? Well, we answered it in this paper because you will see 80% acquired comorbidities after an average of about 4 months of the AF diagnosis. Perhaps more serious, if they had a stroke, how many of them got incident comorbidities before the stroke? Well, the incident comorbidities occurred approximately 4.5 months for 90% of the patients. So what's the answer with regard to assessing risk? You need to do it regularly, and if there are patients you initially define as low risk, doesn't mean you discharge and you never see them again. You probably need to reassess their stroke risk 4 to 6 months later, because very likely many of them will acquire new risk factors. In terms of preventing stroke, well, I think it's probably fair to say that anticoagulation is highly effective. And even in the highest groups of patients, atrial fibrillation is associated with the age and is more prevalent in the elderly. And there are now data showing that even in the real world, if you have very elderly patients, they do derive benefit from anticoagulant therapy. And this is a study we published. We were looking at the extreme elderly. In fact, age over 90. And you will see here, this is done in the era before the NOACs. You will see here for ischemic stroke, compared to no antithrombotic therapy as a reference, irrespective of how you adjust. You see antiplatelet therapy doesn't reduce ischemic stroke, whereas warfarin significantly reduces ischemic stroke. In terms of intracranial bleeding, which is a robust, serious bleeding endpoint compared to no antithrombotic therapy, you will see that antiplatelet therapy, essentially aspirin or warfarin, not significantly different, however you try and adjust for confounding. So the message is anticoagulation significantly reduces ischemic stroke. You'll see aspirin, no difference to no treatment, and it's not any safer either. Hence, guidelines now basically say do not use aspirin for stroke prevention in patients with atrial fibrillation, because it certainly does not confer benefit, it confers potentially harm. And you could also go away from this lecture with the point that aspirin is there to treat the doctor, not the patient. So, on that basis, given the effectiveness of anticoagulant therapy, and given that the default should be for stroke prevention, unless they are low risk, and the fact that the CHA2DS2-VASc score identifies low-risk patients very well, that even a single stroke risk factor confers risk, and that the net clinical benefit for anticoagulation is evident even with a single stroke risk factor, rather than focus on identifying high-risk patients, the first step should be to identify the low-risk patients. Low risk are those with a CHA2DS2-VASc score of 0 in males or 1 in females. Decision, no antithrombotic therapy. The next step is to offer stroke prevention to patients with 1 or more stroke risk factors. Stroke prevention is anticoagulation, so you're making your decision about the type of anticoagulation. If it's warfarin, well, it's not prescribing warfarin and forgetting about it. You pay attention to the quality of anticoagulant control. That's the time in therapeutic range, which has to be about 75%, or these days in the era of the NOACs, the non-vitamin K antagonists, oral anticoagulants. And that can make a big difference. These are data from Asia. These are data from Taiwan, where you will see that in 2008, there was a very low prescribing of anticoagulation. And over these 15 years, you can see how anticoagulation prescribing has increased, arguably by the increased use of the NOACs. What you will see, however, over this 15-year or so period, ischemic stroke, which is the little red dots there, significantly coming down over this time. Mortality, the little blue dots coming down over this time. Intracranial bleeding, which is the little green triangles, remaining reasonably consistent. So you can imagine, as a whole country, you see how there's a marked reduction in ischemic stroke, a marked reduction in mortality, and there's no excess of bleeding by the fact that you increase uptake of stroke prevention strategies with anticoagulation treatment. Now, we focus a lot on stroke prevention, and quite rightly so, because strokes and atrial fibrillation are more likely to be fatal, more likely to be disabling. But then again, we are managing patients. We're not managing a bit of the patient, we're managing the whole patient. Because if we want to manage atrial fibrillation in a holistic manner, we're trying to also improve on symptoms, and this brings in the decisions about rate control and rhythm control. Patients with atrial fibrillation are elderly with comorbidities. You have to address cardiovascular risk factors and associated comorbidities because this is important. We focus on stroke and atrial fibrillation. We forget atrial fibrillation increases mortality independently as well. Of the mortality in atrial fibrillation, only 1 in 10 is stroke. 7 out of 10 of the mortality in atrial fibrillation is cardiovascular. So we need simple and practical decision-making processes, integrated care for atrial fibrillation patients, holistic management of atrial fibrillation. The guidelines have tried to say this. These are the European guidelines from 2016, and it's got all these components of atrial fibrillation management that you will see in every guideline. And it comes out as saying that we need an integrated approach to managing atrial fibrillation, and then it refers to what's called the AF heart team. Then it doesn't say how to do it. How do you operationalize an integrated approach to atrial fibrillation? How do you deliver it? That sounds desperately complex. That sounds desperately difficult. Well, can I persuade you it's not, because you can distill down atrial fibrillation management into a pathway which is as simple as A, B, and C. Well, what is A? Well, A is avoid stroke. A is anticoagulation. And that is what I showed on an earlier slide, where the default is stroke prevention unless they are low risk. A, avoid stroke. What is B? B is better symptom management, patient-centered, symptom-directed decisions on rate control and rhythm control. What is C? C is active management of cardiovascular and other comorbidities, including hypertension, heart failure, diabetes, ischemia, etc. There's a lot of focus on lifestyle changes, things like obesity management, alcohol stimulants, etc. Also focusing on the patient's atrial fibrillation confers a psychological morbidity, and that needs to be addressed with regard to patient values and preferences. Now, an approach like this on the ABC of atrial fibrillation management, that sounds simple. How do you operationalize this? Well, you can certainly work at the local level. This is done together with the West Midlands Academic Health Science Network, and together with partnership with Public Health England and NHS England. And this is primary care clinical pathway for atrial fibrillation detection and management, in keeping with their detect, protect, perfect elements of AF management. And this is atrial fibrillation detection and management on one page. And this was the website if you're interested to download it. It's as simple as that. Atrial fibrillation management is not difficult. What do you have within this? Risk stratification and assessment, detection, then risk stratification. CHAS-VAS, HAS-BLED, that's the same TTR score there. And you come to management, you have A, avoid stroke with anticoagulation. B, better symptom management. C, optimize comorbidity management, the ABC of atrial fibrillation management. Well, we're also in the era of smart technologies, and this is an example how we've tried to apply this. This was a pilot study that we published. This was conducted using a smartphone app, and this is focusing on risk assessment. This is education intervention. This is looking at the patient records and the management plan. And in the pilot study, we showed significantly improved knowledge, drug adherence, quality of life, and anticoagulation management. And this is taken on to a full-scale outcome study that is in progress right now. But these are concepts. These are trying to operationalize it and trying to keep things simple. Well, what about hard outcomes? Well, we started a program of work to try and address this, and this is a proof of concept study where we look as a retrospective look at a clinical trial cohort. Why a clinical trial cohort? Outcomes are adjudicated. And we compared those who were ABC pathway compliant versus those who were not ABC compliant. And if you look here at mortality, the composite outcome of adverse outcomes, hospitalizations, and it's probably fair to say that the ABC compliant patients in the red line doing significantly better than the non-ABC compliant patients. And what's the effect size? Pretty dramatic. Look at mortality, a good 60% reduction. Look at the hazard ratio, 0.35. Look at the composite outcome, also about 60-odd% reduction. Cardiovascular death is reduced. Hospitalization and bed days were also reduced. So we can, with ABC compliant patients, actually make an impact on patient care. Now, this is a trial cohort. This is a retrospective look. We then address this in a contemporary cohort study. And this is an Italian cohort, only about 1,000-odd patients. And you'll see from the Kaplan-Meier curves the ABC compliant patients doing significantly better than the non-ABC compliant. Effect size was consistent with the clinical trial cohort, about 60% reduction in the composite of adverse outcomes. But you can quite rightly ask me which component of A, B, or C is more important. To say all of them, because this is within the atrial AF study, because look here at A, which is avoid stroke with anticoagulation, and this was a cohort on warfarin. So we look at TTR above 65% versus less than 65%. You see how the well-managed anticoagulation do better. This is symptom score by ERA score, those with good control symptoms doing better than those with less good symptom control. C is comorbidity management patients, those actively managed doing better than non-managed, and that's the overall cohort where you do A, B, and C significantly do better. So let me conclude. Atrial fibrillation confers a major healthcare and economic burden. Don't think there's any doubt about that. I've talked about risk and stroke risk, and as well as commented that bleeding risk is a dynamic process. It's not a static process. Management is not complex nor difficult. It is as easy as A, B, and C, because the default is stroke prevention unless they're low risk. A, avoid stroke. You then manage symptoms, and it's better symptom control. C is the cardiovascular and comorbidity risk factor management. An integrated care approach, which includes elements of A, B, and C, will reduce the clinically relevant adverse outcomes and also lower the risk of hospitalization. So management of atrial fibrillation, not complex, not difficult, simple as A, B, and C. Thank you for your attention.